Section 1. The sudden gasp. When breathing fails. Imagine you are on a busy medical surgical floor. It is the middle of your shift. You walk into room 412 to check on Mr. Harrison. Mr. Harrison, 68 years old, 2 days post-op from a knee replacement. He was doing well this morning, even joking about the hospital food. But now, something is different. He is sitting straight up in bed, eyes wide with panic. He is breathing fast, each breath a short, shallow gasp.
I can't catch my breath.
His skin feels clammy. The pulse oximeter on his finger is flashing a dangerously low number. This sudden, terrifying change is a nurse's call to action. This scenario is a stark reality in nursing. Sudden shortness of breath, dyspnea, is a critical symptom. It can signal a life-threatening emergency. It demands quick thinking, sharp assessment skills, and decisive action. Is this a cardiac issue? Is it a complication from his surgery? Or is it something happening deep within his lungs? Two major culprits often present this way: Acute Respiratory Distress Syndrome, ARDS, Pulmonary Embolism, PE. Both attack the respiratory system and cause profound oxygenation failure, but they are fundamentally different disease processes. Understanding these differences is essential for safe and effective patient care. As a nursing student, and soon a practicing nurse, you will be the first line of defense. Your ability to recognize subtle changes, interpret clinical data, and anticipate complications matters. It can mean the difference between recovery and a tragic outcome. This guide is designed to help you build that expertise. We will journey into the complex world of respiratory failure, focusing on ARDS and PE. Our goal is to move beyond memorizing facts and symptoms. We want to help you develop the critical thinking skills to understand the why behind what you see at the bedside. Throughout this discussion, we will explore the core concepts every nurse must master. We will start with the learning objectives. We will evaluate how oxygenation is altered, discuss the risk factors, break down how to interpret assessments, implement evidence-based interventions, and develop comprehensive nursing care plans. By the end, you will be better equipped to face these respiratory emergencies with confidence and competence, ready to act as a knowledgeable and vital member of the healthcare team. Section 2. Your journey as a nurse detective. So why is a deep understanding of ARDS and PE so crucial for you as a nurse? These conditions are not rare occurrences confined to textbooks. They are common, high-stakes problems seen across clinical settings: emergency department, intensive care unit, post-operative recovery floors, patients with sepsis, major trauma, recent surgery, prolonged immobility. Your vigilance in monitoring these patients is paramount. Recognizing the early, often subtle signs of respiratory compromise allows for timely intervention. Prevent progression to full-blown respiratory failure. Prevent progression to shock. Prevent progression to death. To help you connect theory to practice, we will use a special approach called the Nurse Think Aloud. What am I seeing? What does this mean? What could be causing it? What is my priority right now? What do I need to do next? Who do I need to call? This active, inquiry-based learning builds the clinical reasoning and judgment that define excellent nursing. It's about learning to think like a nurse, not just memorizing like a student. Section 1. The Breath of Life. A tour of normal gas exchange. Before we can understand what goes wrong, we must first appreciate how the system is designed to work perfectly. Think of your lungs as two incredibly efficient branching trees. The trunk is your trachea, which splits into large branches called bronchi, then smaller bronchioles, and finally ends in tiny, delicate leaves. These leaves are the alveoli, microscopic air sacs, where the magic of breathing happens. There are about 300 million of these alveoli in your lungs. Their job is simple but vital: to exchange gases. They take in the oxygen your body needs and get rid of the carbon dioxide it does not. For this gas exchange to occur, two critical processes must work in harmony: ventilation and perfusion. Ventilation is the mechanical act of moving air in and out of the lungs. It is the physical process of breathing, driven by your diaphragm and intercostal muscles. Perfusion, on the other hand, is all about blood flow. The pulmonary artery carries deoxygenated blood from the right side of your heart to the lungs. This blood travels through a vast network of tiny capillaries that wraps snugly around each alveolus. This intimate contact between air and blood is where the exchange takes place, a process known as diffusion. Imagine each alveolus as a tiny loading dock. When you inhale, fresh oxygen arrives. The deoxygenated blood, rich in carbon dioxide, pulls up. The walls of the alveoli and capillaries are incredibly thin. This allows oxygen to easily pass, and carbon dioxide moves in the opposite direction. This newly oxygenated blood then travels back to the left side of the heart. The vast majority of it binds to a special protein within our red blood cells called hemoglobin. Think of hemoglobin as the dedicated delivery truck for oxygen. This efficient system ensures that even the most distant tissues in your body receive the constant supply of oxygen they need to function, produce energy, and sustain life. Section 2. When the lungs flood, defining ARDS. Now let's consider what happens when this beautifully orchestrated system is violently disrupted. Acute Respiratory Distress Syndrome, or ARDS, is not a specific disease itself. Instead, it is a severe and life-threatening form of respiratory failure. It is a catastrophic inflammatory reaction within the lungs. The simple way to picture ARDS is to imagine the lungs are flooding. The delicate, air-filled alveoli become waterlogged and inflamed. This prevents oxygen from getting into the blood, no matter how much oxygen you give the patient. The core of ARDS pathophysiology is widespread injury to the alveolar capillary membrane. In ARDS, this barrier becomes damaged and leaky. This damage can be caused by a direct injury to the lungs, like pneumonia, or an indirect injury, like sepsis or severe trauma. Regardless of the initial trigger, the result is a cascade of destructive inflammation. As the alveolar capillary membrane breaks down, fluid, proteins, and inflammatory cells from the blood to pour into the alveoli. This protein-rich fluid is called exudate, and it deactivates a crucial substance called surfactant. Surfactant keeps the tiny air sacs from collapsing when we exhale. Without functional surfactant, the alveoli become stiff, unstable, and prone to collapse. The combination of fluid-filled alveoli and collapsed alveoli creates a severe problem known as shunting. The blood flows right past the flooded alveoli, unable to pick up any oxygen. The result is severe hypoxemia. This is a hallmark of ARDS. The hypoxemia is often refractory, meaning it does not improve much even when the patient is given 100% oxygen, because the oxygen simply cannot cross the flooded barrier to reach the blood. Diagnosing ARDS involves piecing together several clues: the patient's history, clinical presentation, imaging studies, and lab values. The most widely accepted framework for this is the Berlin definition. This set of criteria helps standardize the diagnosis and classify the severity of ARDS. First, respiratory symptoms must have started within 1 week of a known clinical insult. Second, a chest X-ray or CT scan must show bilateral opacities. Third, the respiratory failure cannot be fully explained by heart failure. The fourth criterion is a specific measure of impaired oxygenation, the PaO2 over FiO2 ratio. In ARDS, this ratio falls significantly, and its value determines the severity: mild, 201 to 300, moderate, 101 to 200, severe, 100 or less. The ABG will show a low PaO2 and may initially show a low PaCO2. As the disease worsens and the patient tires, the PaCO2 will rise, indicating ventilatory failure and respiratory acidosis. Let's shift our focus now from the alveoli to the blood vessels that supply them. While ARDS is a problem of lung inflammation and fluid, a pulmonary embolism, or PE, is a problem of plumbing. It is a blockage. A PE occurs when a substance, most often a blood clot, travels through the bloodstream and gets lodged in one of the pulmonary arteries in the lungs. Unlike ARDS, which typically develops over hours or days, a large PE can be a sudden, catastrophic event, a life-threatening situation, known as a saddle embolus. It is crucial to understand that a PE is fundamentally a perfusion problem, not a ventilation problem. When a PE occurs, the air can still get into the alveoli just fine. The problem is that blood cannot get to those ventilated alveoli. This creates a situation where a portion of the lung is being ventilated but not perfused. This is the exact opposite of the shunt we saw in ARDS. Here, we have a large area of what is called dead space. Dead space ventilation is essentially wasted breathing. The patient is expending energy to move air into a part of the lung that has no blood flow, so no oxygen can be picked up and no carbon dioxide can be dropped off. This is why sudden, unexplained shortness of breath is the most common symptom of a PE. The body is screaming for oxygen that it simply cannot get. The harmony between ventilation, V, and perfusion, Q, is essential for effective gas exchange. A pulmonary embolism throws this delicate balance into chaos, creating a profound V by Q mismatch. Blood is diverted away from this blocked segment. This sudden diversion dramatically increases the pressure within the pulmonary arteries. The right ventricle of the heart is suddenly forced to pump against this extreme resistance. This sudden increase in afterload on the right ventricle can lead to right heart strain or even outright failure. This leads to a drop in cardiac output and systemic blood pressure, a condition known as obstructive shock. Some patients may cough up blood, a symptom known as hemoptysis. The irritation of the pleura can also cause sharp, stabbing chest pain that worsens with deep breaths, known as pleuritic chest pain. Section 3, the danger within, risk factors and telltale signs. The risk factors are famously encapsulated by Virchow's triad: venous stasis, endothelial injury, hypercoagulability, post-operative patients, major surgery, active cancer, oral contraceptive pills. Pregnancy is also a hypercoagulable state. The most common presenting symptom is the sudden onset of dyspnea, pleuritic chest pain, a sense of anxiety or a feeling of impending doom. On physical exam, the patient is often tachycardic, heart rate greater than 100 beats per minute, and tachypneic, a rapid respiratory rate. You might also find signs of a DVT in the patient's leg, unilateral swelling, redness, warmth, and pain. Finding a DVT in a patient with sudden respiratory symptoms is highly suggestive of a PE. Section 4, the hunt for the clot, diagnosing pulmonary embolism. The first step is to assess pretest probability. Clinicians use standardized scoring systems. The Wells score is common. For low or moderate risk, a D-dimer blood test is often next. D-dimer is a protein fragment produced when a clot dissolves. A negative D-dimer has high negative predictive value, PE unlikely. A positive D-dimer is less specific. A positive D-dimer means further imaging is required. The definitive gold standard imaging test is CT pulmonary angiography, CTPA. Contrast highlights blood vessels so filling defects stand out. The radiologist identifies filling defects confirming presence, location, and size of the PE. An EKG may show right heart strain. Arterial blood gas typically shows hypoxemia. Bedside echocardiogram can show a dilated right ventricle in unstable patients. The management of ARDS is complex and primarily supportive. There is no single cure. The cornerstone of ARDS management is mechanical ventilation. The main principle is low tidal volumes, to prevent overdistension and injury to fragile alveoli. Another crucial component is PEEP. Its purpose is to prevent the alveoli from completely collapsing. By keeping the alveoli open, PEEP can improve oxygenation. For severe ARDS, prone positioning can be a game changer. This involves turning the intubated, sedated patient onto their stomach. The benefits can be dramatic. Conservative fluid management is another key strategy. The modern approach is keeping the patient on the dry side. Unlike ARDS, the treatment for pulmonary embolism is targeted directly at the cause, the clot. The mainstay of treatment is anticoagulation. These medications do not actually dissolve the existing clot. They interfere with the clotting cascade, giving the body's own natural clot-busting system. Time to break down the embolus. For patients who have a massive PE and are hemodynamically unstable, this is achieved with thrombolytic therapy, using drugs like alteplase, powerful clot busters that actively dissolve the thrombus. A more targeted alternative is catheter-directed therapy. They can deliver a lower dose of thrombolytic medication directly onto the clot, or use mechanical devices to break up the clot or suction it out. In some specific situations, an IVC filter may be placed. Its purpose is to act as a net, catching any future clots before they can travel to the lungs. As a nurse caring for a patient with ARDS or PE, you are the vigilant guardian at the bedside. Frequent respiratory assessments. Listen to lung sounds. Continuous pulse oximetry. Regular ventilator checks. Prone patient. Skin and pressure point care. Hemodynamics. Track heart rate, blood pressure. Manage invasive lines. Monitor labs. Be ready to escalate. Know who to call and use SVAR. Situation, background, assessment, recommendation. Your clear, concise reporting ensures the entire team has the information needed to make timely and effective decisions. A deep understanding of the pharmacology used to treat ARDS and PE is essential for safe nursing practice. Heparin requires frequent APTT monitoring. You must be vigilant for signs of bleeding, and be aware that the reversal agent is protamine sulfate. For long-term treatment, patients are often transitioned to oral anticoagulants like warfarin, or the newer direct oral anticoagulants, DOACs, which have fixed dosing schedules and no routine lab monitoring. For the critically ill patient with ARDS, sedation and analgesia are key. Your role includes using standardized sedation scales like the RASS to titrate these infusions to the lightest effective level. If the patient is in shock, you will administer vasopressors. These drugs constrict blood vessels to raise blood pressure and improve organ perfusion. Managing patients with ARDS and PE extends beyond respiratory and hemodynamic support. Nutritional support is key. Preventing hospital-acquired complications is central, like ventilator-associated pneumonia, pressure injuries, and deep vein thromboses. Even when sedated, patients may experience delirium. Regularly assess for delirium and implement non-pharmacological interventions. Reorient the patient and encourage family presence. Communicating with the family is a vital role. Provide clear updates, explain complex equipment, and offer emotional support. Patient education is continuous. For the ARDS survivor, recovery can be long and difficult. Connect them with resources like physical therapy and support groups. Throughout our journey, we have explored two distinct and dangerous paths that lead to acute respiratory failure: acute respiratory distress syndrome and pulmonary embolism. ARDS is a problem of the lung tissue itself, creating a physiological shunt. In contrast, PE is a circulatory problem, creating physiological dead space. Both ARDS and PE cause a profound V over Q mismatch, leading to the shared outcome of severe hypoxemia. Furthermore, the conditions can be interrelated. A critically ill patient with severe ARDS is a major risk factor for developing a PE. Conversely, a massive PE can cause profound shock that may trigger development of ARDS. Your role as a nurse detective is to use your assessment skills to find the clues that point towards one diagnosis over the other. The patient's history is paramount. By grasping the why behind each disease, you become more than a task doer. You become a critical thinker capable of navigating the nuances of respiratory emergencies. As we conclude, it is essential to reinforce the indispensable role you play as a nurse. Your vigilance is the patient's primary safety net. To practice your clinical reasoning, constantly ask yourself reflective questions. This internal dialogue, this thinking like a nurse, is a skill that you must actively cultivate. Remember that you are never alone in this fight. The care of a critically ill patient is a team sport. Your collaborative spirit is vital to orchestrating the complex care these patients require. Finally, embrace the reality that the field of medicine is always evolving. Commit yourself to being a lifelong learner. Stay curious. By combining your knowledge with compassion, your skills with critical thinking, and your individual efforts with teamwork, you will make a profound difference in the lives of your patients and their families. Breathe easy, knowing you are prepared for the challenge.